would I think that 15 minutes twice a week even though they did strength training and they increased the loads.
Come on, Fred, you spend time. You spend time under the bar.
Absolutely, yeah. I'm trying to be nice.
Right,
no,
it's
trying to be
nice. So yeah.
No.
So do you believe it? Do you believe this study?
I believe this. The study is what we're seeing. I believe their data.
Right.
But I don't think it's because the strength training doesn't work. I mean, that's not what I'm thinking here.
Right. So the issue, anything else that you want to say to sum up before I launch into a tirade here? Okay. So we made quick work of that one. The next couple of papers are for you, beginning with the two Jacobsens. Are we going to do these in chronological order?
Yeah, let's do them in the way that I think that Jacobsen thought they were doing.
All right.
So
go ahead and introduce them.
All right. So this article is the first one we're going to talk about is Perspectives in Rehabilitation. Progressive Strength Training 10RM commenced immediately after a fast-track total knee replacement. And the question, is it feasible?
Is it feasible?
Is it feasible? Well, I hope so, because he tells us that, right? Disability and Rehabilitation, 2012. And this is from Thomas, Lindig, Jacobsen, and Henrik Husted from the University of Copenhagen.
University Hospital in Denmark, yeah.
Right, and they do a lot of work on this fast track stuff. So this is an interesting beginning here. So the idea is that knee replacements and fast track knee replacements, real quick. Everyone kind of knows about knee replacements. We're doing 700,000 of them in the United States yearly now. That basically is fast track is taking the patient and looking at that person from many, many ways and really taking a normal person and doing a replacement part, like you're changing a car battery. That's the theory. So a person goes in, they're not considered a patient. They're not a patient. They're going in, they can multiple times wear their street clothes, and their operative, their rooms are more of a hotel room looking thing, and they're really convinced that they're really only there to get a part fixed. And with that and multiple other things, you can get the patient in, have the surgery, and they have a very short length of stay with pretty good satisfaction and no increases in morbidity and mortality. So that's the idea, and it's constantly looking to get the patient better. That's the fast track idea. So what they did here is they said, well, one of the biggest things you see with knee replacements is the significant quad weakness after the knee replacement, and 60 to 80% weakness, post-op of that quad mechanism. And so what these guys figured, it makes sense that maybe we can immediately start to strengthen and see if it's possible. Is it feasible to do so? So what we did here is start the pilot study. So we had 14 patients, 8 women, 6 men, mean age of 70, BMI 28, and put them in the fast tracks knee replacements. And they went a progressive strength training program 3 times a week for 2 weeks, directly after surgery, usually within 2 days of the surgery. Now their rehab, the normal rehab that they would get anyway, it's about an hour long. And they'd get 10 minutes of gait training, 5 minutes of unilateral active assisted range of motion of the knee, and then they'd get 20 big minutes of unilateral progressive strength training, and 15 minutes of functional walking, 5 minutes of balancing, and 5 minutes of stretching. And they did that a couple times, 3 times a week for 2 weeks, and they had six times. And during that time, they assessed the training load, the amount of pain, the swelling of the knee, their walking speed, knee extent, the isometric extension, strength, knee range of motion, patient reported outcomes, and an x-ray of the patella, which I got a kick out of because I did that a long time later to see if it was dislocated. I think they would have known that real quick.
That seemed odd to me as well.
Yeah. Well, I see the way I read this is it's done from the Department of Physical Therapy. So I understand that the surgeon is now saying, okay, I'll let you do this study, but I don't want you to screw up my knee. So the idea is I'm going to push that medial capsule a lot, and maybe the medial retinaculum where I sutured it back is going to get pushed more than I'd want it to be, and now my knee cap's going to sublux laterally. That's the worry. But what they found out is their training load increased 113% for the leg press, 464% for knee extensions. Their pain was controlled, basically. They had they actually had decreasing swelling as would happen normally after surgery, and they had an increase in walking speed, and their patient-controlled outcomes were fine. So their idea is, hey, it worked. Now, when you really look at it, all these great training experiences, you have you have surgery done, and after that operation, you have profound weakness, and the patient is now slowly going to improve daily. All right. And so, yeah, you're going to see increases, and you're putting them through this. And I tell you one thing, I've done a lot of knee replacements, and I'm looking at the timing of how they do this. There is a normal, and they said potentially maybe some of this is secondary to just natural healing. But the reality is that they have these tremendous improvements, which is coming from almost zero. If you're losing 60 to 80% of your extensor strength after that surgery first time, and then you're just improving it back, you never bring it up to normal. But they were able to do it, and they said at the end, okay, this is a feasible thing. And looking at their data, they really just showed that the pain was controlled, that their loads were increased, and the patients did have increasing strength, but really their baselines weren't that great, which you'd expect. But I think that this study allows them to go to the next thing. That's really what this is, and so the interpretation.
Yeah, go ahead.
I figured, well, the progressive strength training was feasible, and I think it's feasible too. But I'm thinking to myself, I think we're going to have to have some further investigation, which is what he did 2 years later.
Right. So this simple feasibility study in which the authors made the patient stronger using a simple progressive overload program doesn't really tell us how much good it did, whether it really did any good, although it did make patients stronger, which is good in itself. But that's the point of Jacobsen's next paper. So why don't we just go right to the next, next Jacobsen?
Okay, so
which is a little bit more meaty, and
there's a lot more to it now.
Yeah, right.
Okay, so now we're going to look here at early progressive strength training to enhance recovery after fast track total knee replacement, a randomized controlled study by Thomas Lindig Jacobsen, and Dr. Husted's there as well.
Okay.
And this is from Arthritis Care and Research from 2014. Okay, now what this is here, we have the same idea. So we're talking about now that we have a study we show it's feasible to begin strength training. What we did is we have a randomized control study where it took 82 people with unilateral total knee replacements and randomized them really to 40 initially with the rehab with a progressive strength training component, and 39 without the progressive strength training. And we did a 2 times a week for a 7-week intervention. We have even less strength training on this than we did on the feasibility study. Okay, so
yeah, we're definitely more on that.
Yeah, we've got a training 2 times a week for 7 weeks, and with all the other rehab that both got, in a nutshell, the arm that goes on to have strength training, resistance training, in knee press and knee extension, leg press and knee extension, really had 15 minutes of that exercise twice a week, and do everything else the same. So they were looking for, they're using validated outcome studies to assess
standard assays.
Stuff, right? How we do it. And then when you're going through their data, they really have they find no significant difference between the standard rehab and the progressive strengthening training on anything, really. Basically on their progressive, on their primary or secondary outcomes. And when you look at the data, I mean, there's plenty there, and there is really no statistical difference. And so you say, well, why? You know, like I said, why that? We know that's strengthening, but also when you're taking a patient, and I looked at it, first of all, it's a little bit different. We didn't know what kind of knee replacements they did in the feasibility study, but here they do tell us. And they're doing several different types of knee replacement. They're all either cemented or non-cemented, and there are with a rotating platform type. So there's different knee replacements. So each of those have their own little differences. The other thing they are using is they've used tourniquets, and a tourniquet by itself initially can be seen with some weakness. When you look at patients who've had knee replacements done with a tourniquet and without a tourniquet, one of the findings that we see is that there is increased weakness with the tourniquet. The majority of patients will have tourniquet use, but there is weakness. And since we're just watching this, I'm saying, well, they've all had maybe that part of that variable that I haven't talked about.
Now, just to clarify for our listeners who aren't surgeons, the tourniquet is to give the surgeon a more bloodless field, right, to work with?
Yes.
Right. Okay.
The idea is to do no bloodless field, and the reality is that when you look at studies between tourniquet use and non-tourniquet use, there really isn't too much of a difference in blood loss. The only thing is, on a cemented knee replacement, you really want to have a bloodless field for the cement, the methyl methacrylate to set better. So even in a tourniquetless operation, some people put a tourniquet up for 5 minutes so that the cement cure. But that throws another variable in. But the idea is that there is a weakness right there. So when I'm looking at a study, and I feel bad for Jacobsen because I think they were looking for a positive thing here.
Oh yeah, yeah,
you know?
They were. They were. These guys were disappointed.
Yes.
When they got their data.
Yeah, but I think for the most part, I look and say, all right, there is no difference, and I'd say, well, would I think that 15 minutes twice a week even though they did strength training and they increased the loads.
Come on, Fred, you spend time. You spend time under the bar.
Absolutely, yeah. I'm trying to be nice.
Right,
no, it's
trying to be nice. So yeah.
No.
So do you believe it? Do you believe this study?
I believe the study is what we're seeing. I believe their data.
Right.
But I don't think it's because the strength training doesn't work. I mean, that's not what I'm thinking here.
Right. So the issue. Anything else that you want to say to sum up before I launch into a tirade here, or do you have your own tirade?
Well, I've got more tirades coming, I think, because I'm looking at again, multiple different knee replacements that have their own little things.
So you have you have a heterogeneous study population.
Right. I have a very minimal amount of strength training compared to the standard, which I don't know is enough to make a difference, right? Even though the data shows me it doesn't make a difference. I have a tourniquet usage, which they both had tourniquet usage, so I guess that can wipe that out. And the other thing is that they're looking at this. They used a different study. The 6-minute walking time, which is a validated, common
outcome
measure, which, for the most part, isn't really what they tested on their feasibility study. And I'm wondering if they could have kept it closer to that, they would have seen a difference between the two. And the other one, they did mention about arthrogenic inhibition at the end as that their reason for that. Now, that's kind of like lack of voluntary.
Yeah, but they didn't see it. They didn't have to invoke it in their first paper. Where they showed a difference in strength, right?
Right. But I think what they did there is, remember, they just took patients who just had a knee replacement. That operation was just done, and now we have somebody who's got, by just that operation, 60 to 80% weakness in their extension. And so now they're just going to start doing anything. And in many ways, I always think about the novice effect. You could do anything. You could have, balanced Pop-Tarts on their heads, and they probably would have got stronger, right? So
exactly. Exactly. Right. So I think you've hit some of the big problems here. And again, if these authors had a bias, it was not towards finding a negative result. I think they were. Oh, yeah. They're pretty committed to this. Again, I agree with you. The sample is heterogeneous in age. The study is small. It's bigger than the first one, but it's still small. It's short, and the power is inadequate.
It was 80. Not only that, but when they talked about the power, eventually, it had people dropping out too. So they just made it. So it's not a very well-powered study. They didn't give a lot of time, as far as I'm concerned, to make 15 minutes twice a week to be the point of it.
You and I both know that is a homeopathic dose of strength training medicine.
Right.
They say they were powered to 80% to detect the difference of 15% or 60 meters in 6 minutes. So according to my back of the envelope calculations, if there had been an improvement of 10% or 20 meters, which is not clinically insignificant, their study would not have been powered to detect it. Right. And none of the secondary outcomes were considered in the power analysis: strength, mobility, quality of life, or whatever. But Fred, here's the real issue. You have one group that got the PT only, and the other group that got the PT plus the strength training. And the PT plus strength training group didn't get stronger. Now, that's in stark contrast to the pilot study, where the patients did get stronger.
Right.
So neither group in this study got stronger. So what does that say about your experimental strength training intervention? It says you're doing it wrong.
Absolutely.
Right? So, let me give you an analogy. Let's say you wanted to give a compound, an experimental drug, because you think it will improve walking distance, right? And it does this by promoting the activity of enzyme X. And one group gets physical therapy plus the compound, and the other group gets standard physical therapy and no placebo, by the way, in this experiment. Mm-hmm. And when you find that both groups are the same for walking distance, and you conclude that the compound didn't work and enzyme X doesn't affect walking distance.
Right.
When you look at the change in enzyme X, you find no difference, however, between the groups in enzyme X. So that's exactly what these guys did. They gave a compound, a medicine, strength training, to see if it would improve walking distance. They observed no biological effect of the medicine, no difference in strength outcomes. And instead of realizing that maybe they had an ineffective administration of the medicine, they concluded that the medicine didn't work. So if you administer a strength training program and it doesn't increase strength compared to a control group, you're just doing it wrong.
Right.
They come up with all sorts of reasons why it might not have worked, like this arthrogenic inhibition, right? And based on the discussion, I really feel like they were disappointed that it didn't work. But concluding based on this paper that strength training has no role here is entirely premature, because if you want to use strength training, see if you get a secondary therapeutic effect, you have to make sure that the strength training medicine is being delivered and is biologically active, which means it has to make the experimental group stronger. So I think these guys are asking the right questions. And I hope they continue this research, and I really hope that their surgeons were not holding them back. Okay, you get 15 minutes. You got 15 minutes to work on my knees, right? No more. That's right. I can hear it in my head.
Yeah.
So
because we don't want infections, we don't want fractures, we don't want blood clots, we don't want any of that stuff.
Right. I'm not sure we can learn much from this, except maybe how not to do a strength training program in post-TKA patients.
Yeah. It's a training program. It's got to keep going. It's not like, even the other articles I've looked at that were similar, just, in preparing, they have these short term, even if they're longer, they're short term. They just say stop as if the person goes on like, you round them up, or they're in space and you hit them and they don't need anything else because there's a vacuum and they keep going. No, they have to get onto that training pole,
Right, the long-term program.
Yes.
So I think we have another joint paper coming up a little bit later.
We do.
While we're on this topic, I think I'd be remiss if I didn't point out to our viewers the really excellent review of training with the artificial joint by our friend and fellow Grace Stewart Research Review faculty, Dr. John Patrizio. He's from the Department of Exercise Science at Adelphi. You can find this over at the Starting Strength website, so it's not peer-reviewed. Damn, it could have been, because it's great. Really just a nice narrative review of what we know about this topic. You got a chance to look at it?
Yeah, I read it actually. I thought it was really well written, and it really went through a lot of
it really clarified for me a lot about this, and so make sure you give it a look, everybody. The link is going to be in the show notes.
And actually, he kind of acknowledges the two papers we just mentioned.
Yeah, he did.
Which is interesting, Yeah. And I think that I think it just shows you that you have to in the clinical realm, you don't have a lot of great kind of like another realm, if we're talking about that peer-reviewed material isn't really enough to help you, but he knows what he's doing with
lots of heat, little light.
Yes, absolutely.